Now it's a pleasure and privilege to welcome again Professor Michael Huepfl, Professor of Anesthesia and Surgical ICU in University of Vienna. In the coming 25 minutes, he will discuss the perioperative coagulation monitoring.
Okay, challenge accepted. As long as the computer is setting up, I want to thank you for this introduction. Thank you very much, and I hope the presentation will come, but if not, I will talk. So, as Professor as Manat told you, I'm from Vienna, Austria. I have been talking in the morning, and I usually start with the conflict of interest, and I give you only an update. In these 2 hours, nobody approached me and gave me money that my conflict of interest has changed now. So it's still the same like it's in the morning. And my focus here is monitoring of coagulation in the perioperative period. The perioperative period is before, during, and after it. And we have different tools to work with. Usually, our patients come and we are looking at this coagulation thing. This coagulation, we loved it during studies because there were lots of arrows and lots of factors all together. It was hard to understand. And now it became even more complex. We have this first special force, if something is broken, the special force of the thrombocytes running there and trying to fix the hole there. And after that, there is the glue coming and putting this together that this hole is closed. That's the easy explanation for it. And this easy explanation is not that easy. And there are lots of factors there. And the real challenge is that this is a system that's in excellent balance. And this balanced thing, that's the real challenge here, that we get this balance done. If we don't have it, our patients are bleeding or they have thrombosis. And usually what nature does works quite well. In the moment we come and intervene, it's not that easy and not that good usually. So that's one of our big goals, that we have these intervention or this balance still provided, even if there is an intervention, what we need to do. And let's say, nature has not planned us us as surgeons, us as doctors, and nature has not planned that one cuts the other and sews it together again. And so this is quite an intervention that is not planned from nature. And our tools are not that sensible to really get the balance like it should be. So one side is the patient, one side is the body of the patient that works and tries to have this perfect balance of coagulation system, and the other side is medicine. Medicine, and I had, and you see here this excellent graphic here about all these interventions we have intervening in coagulation. And the graphic that you now have to imagine is a graphic that was done by a company, and the company says, this is the market, that's the market for the future. So anticoagulant agents are a big economic thing. So one side we have the patient with all his good things, trying to get the coagulation done, and also with his weaknesses, if the liver is not that good or thrombocytes are not, so his problems. And on the other side, we have medicine who interacts to quite many places in this coagulation system. And that's now the moment, that's the situation we are facing. And now our patients come to us and they have a scheduled operation. Let's make it with a little bit less stress, not the acute and the emergency thing, but the planned one. And now we are in the interview, we are in the examination of our patient. We are doing lots of laboratory findings to find out, is everything okay? And in the morning there was a discussion about when should we stop aspirin, should it be 2, 7 days, whatever do we do? And let's keep in mind, it's again this patient. The influences of the patient with all his elements he's bringing. And then on the other side, it's the influence of the medication. Was all the medication really in the patient, or did something go through? Is the medication with the right dosage there? Is this a responder or not responder? Lots of things that we cannot really know alone with the dosage of the medication. Yeah? Because if you look around, it's if I take one pill of aspirin, it will be another dilution than if my friend Abir takes it, because there's another dilution factor. So that's what we are facing. Patient comes, and now we have to evaluate what should we do that this also works in the operation. What do we need to, what findings do we need? And there are some studies looking at this classical coagulation tests. And they tell us, look, if you do all these tests, that doesn't help you. The thing that's the most powerful thing is talk to your patient. Make a structured interview of his coagulation the coagulation history. Ask the patient if he gets very easy hematomas. Ask if there's something, a little wound, does it bleed longer? Ask if the period of women is longer than we would expect it to be. Ask your patient. That's the most powerful tool, much more powerful than only these laboratory findings. Of course, if we have some special questions, then go to the laboratory, then ask the guys there what would be the best thing. Would it be the standard findings? Would it be something special? Do we need a multiplate that really looks at the thrombocytes and what they can do? So that's the first big part. Preoperative evaluation, and preoperative evaluation, try to get the information from your patient, from the history and how he or she performs in daily life with some coagulation questions. In Austria, where I come from, the Society for Anesthesia has made a standardized form to ask this coagulation history from the patients. And I think that's a very good thing, that we do not miss some doubts somewhere. Huh? So I think this could be also something that not only makes it more efficient, but it even makes it cheaper. Yeah? Because if we do things that we do not need, we shouldn't do them. So that's the preoperative period. And now we are going in the operation, during the operation. And we also have our problems there. We also have, no, we don't have problems. I learned if you say problems, you can solve it. Say challenges that can be solved. So we have challenges there. The challenge is we are in a dynamic situation. We are in a situation that's maybe not expected. And time is running. This dynamic thing is something that is the difference between us and pilots. If you have pilots, you usually have nobody who is working on the airplane in the same time. But that's what we have. When we are in the operating room doing the anesthesia for our patient, the surgeon is trying to fix the patient. Yeah, that would be like you're flying with the airplane and the mechanics are working on the airplane. So much more dynamic than it is, or than in other things. So, okay. So what to do then? Again, if something is very dynamic, our static findings from sending it to the laboratory will be maybe too slow. So they will tell us something. They will tell us something that's already gone, you see. Got it. So that means we need something to tell us what is happening now. What is happening now and what can I do? And so, on one side, we need some laboratory findings, like blood count. I need to know what is in. Are there still thrombocytes here? Of course, I also want to know what are the red blood cells and how much is here. But also the static values, but I need something a little bit quicker. And that's the thing where we can use this point of care coagulation testing. Thrombelastogram, thrombelastometry, with ROTEM and TEC, that are these abbreviations there, that are all things that can help us. But another very powerful thing is, let's walk around the fence and look in. Watch, how does it look like, the bleeding there? We usually see a desperate surgeon, trying to fix that. But it's important for us, how does the bleeding look like? Is it these little points coming up? Or is it this big hole where blood comes out? That needs different approaches. If it's the big hole, our surgical friends want us that we can do something with the coagulation, but they have to fix it if there's a big hole. If there are these little stitches coming up, yeah, of course, then coagulation is something we need to optimize. So again, what we are heading for is this balance. We want this balance that this patient is not bleeding, but also not getting in a thrombotic situation. So this would be one of these ROTEM where you can put in blood, and it shows you after about 10 minutes you know how quick and how strong your clot is. Yeah? And also it will show you if you have a hyperfibrinolysis afterwards. And that's something you can do bedside. That's something that can be in front and can be next to our working place. So this is the coagulation monitoring that's functional. That's the same like a chest X-ray for having a view on the heart and then echocardiography. Yeah, chest X-ray, nice, but echo will tell you, sonography of the heart will tell you how this heart really works. And so here again we have our static parameters, and we have this where we see, look, that's how the clot comes. That's the impression, how much fibrinogen we have, where we need a little bit more. And it's not that complicated. It's also not the easy thing like blood sugar testing, but it's not that complicated. And we were talking about the thromboelastography or metry. It's about the same technique, but one thing is a little bit more for a little bit. You can see a little bit more in there, the rotating the ROTEM in there. So that would be such printouts you will get if you do these functional things. But if we know then what's the problem, that doesn't mean that we know how to solve it or how we solve it. So it makes sense that you have a protocol. It makes sense that you have a protocol for coagulation management, for a massive hemorrhage protocol, and that these things are together, these steps are adapted to local protocols, and that in the moment you come in this dynamic bleeding situation, you can go on with your protocol and your standard. And here we saw also in studies a very good impact of these protocols, that starting early, starting focused, and here makes the situation much more stable, much more safe, and you use less blood products than you would do without such a protocol. So we talked about preoperative, we talked about what will we do when it happens during the operation, but there is also a part that we should focus even more than we do it now. That's postoperative. Very often our specialty does not really see the patients afterwards. But now, these are these patients. These are the patients who have their needs to be anticoagulated, where their threats are myocardial infarction or stroke. That was something before the operation, and now they are in a usually hypercoagulable situation. So we again have to get them in the balance. We have to get them in a situation that their coagulation status is adapted to their needs. So we have to ask, is this patient bleeding? Is there a bleeding risk? Of course, we take the laboratory assessments to know where is this patient now. And then we have to ask, how is the risk of thrombosis of this guy, of this woman? Because this is one of #1 death reasons, postoperative thrombosis, pulmonary and embolism. So we have to focus on that. Usually our surgical friends are focused that nothing is bleeding, but we are focused on the whole patient. And we know that if this patient is not bleeding, but the coronary arteries of this patient are closed, that doesn't help him at all. So getting this again, together with the medical history, together with the information we had from before, we need to focus to get this patient very, very quick to a situation that he or she is safe. So to summarize, I had the chance to give you a little story about the challenges we face. Then we talked about the tools we have and focused a little bit on this point of care testing during it, and talked what should we do and when should we do it. Thank you very much.